familiar with the roller trial. It was a prospective randomized trial in which patients were randomized to laparoscopic or robotic. There were 40 surgeons in 29 institutions over 10 countries, some of them in Asia. The main thing here is that the surgeons participating in the study had performed more laparoscopic procedures than robotic procedures. Those are the numbers. There was no difference in operative time, in time spent in the operating room, the length of stay, the need for a permanent stoma, or the circumferential or sexual margin involvement, or even in complications. The study was powered to demonstrate reduction in the conversion rate. And it came short of showing the difference. The conversion rate for the laparoscopic group was 12% versus 8% in the robotic. Subgroup analysis always saw a trend towards lower conversion rate in the robotic group, but the difference were just barely statistically significant. Now, what was the problem with the roller trial? I think, as I mentioned before, surgeons had different experience with each technique. Probably many of them were in the learning curve of the robotic technology. And I think the main problem is that the conversion rate in the control arm, in the laparoscopic arm, was lower than originally anticipated. The study was powered for a conversion rate in the laparoscopic arm of 25%. And it turns out that it was half of that. So the study at the end of the day was underpowered to show any difference in the primary outcome. The issue being that is whether the primary outcome was even meaningful. Again, there are many things that you cannot measure when you do clinical trials in surgery, and that is the main problem. Now, at our institution, we never really did much of the many cases of a total mesorectal excision truly laparoscopic. As I mentioned, we used to do a hybrid procedure where we mobilized the colon laparoscopically and then did the TME for the most part through a small fan steel incision. So I call those cases open, even though part of the operation was done laparoscopically. We have compared with cases in which we have done the entire procedure using the robotic platform. And we have looked over 600 cases of robotic to almost 400 cases open. And again, this is our patient population. They're in the 50s, most of them males, our BMI is in the high 20s. And this is the location of the tumor, the use of neoadjuvant therapy, which is just representative of what we use in our institution. This is the procedure that we perform, LARs, APRs, with LAR with or without ileostomy, and how we do the anastomosis, hands-on versus staple. The operative time, again, this includes the learning curve of at least 6 of the 8 surgeons that participated. Again, even with the learning curve, it took a little longer, but not by much. The estimated blood loss was less. Our conversion rate is only 2.7%, significantly lower than has been reported with laparoscopy. Complication rates went down, length of stay has gone down, and the readmission in 90 days has gone down. I must admit that there have been other things that have changed in those years, in addition to the implementation of the robotic platform, but I think the robotic platform has contributed to improve our outcomes recently. When it comes to surrogate oncological outcomes, such as the positive circumferential or sexual margin, the length of the distal margin, the millimeters of the circumferential or sexual margin, or the quality of the mesorectal excision, has been very much the same, if anything better. For whatever the reason, the number of lymph nodes harvested has gone up. When it comes to recurrence and survival, the results have been the same, even taking into consideration that recently patients who have a good response to neoadjuvant therapy and definitely have better biology are now treated with watch and wait. So even though we have changed the population of cases, the results have remained the same, no difference in recurrence or survival. Again, there is some problem with retrospective data. There is the problem of potential case selection. Again, includes the learning curve. We use historical controls, and again, other variables have changed over time. But our overall experience is that our outcomes have improved in recent years with the introduction of the robotic platform. I want to touch upon the TME. This is a procedure that has received a lot of attention recently. TME is an old procedure that we have always used. We have used it when a coloanal anastomosis is needed, when the tumor is so low that we don't have enough room to put a stapler from above, and we need to just detach the rectum from the sphincter complex transanally to perform a hands-on coloanal anastomosis. In this case, we have always done it, starting the dissection at the level of the dentate line or slightly above, and then extend the dissection from the bottom up using conventional transanal instruments, the Pratt by Ball, the Ferguson, the Parks. And then we just do the dissection for a few centimeters, and then we just come from above. Often we extract the specimen through the anus and then just perform a hands-on coloanal anastomosis. So this is an old procedure that we have always done. We have tried a few times to use the laparoscopy to try to stent the dissection from the bottom up a little bit more, but I have been very unimpressed, particularly with the technical difficulty. I think this coming from the bottom is challenging because all the transanal techniques are difficult. The space is very narrow. The mobility is limited in between the legs of the patient. The instruments are crowded because you work through a very small hole. There is a crowded of the instrument. And I represent here something that I call the reverse funnel effect. When you come from above, you go from wide to narrow. When you come from below, you are start narrow and you try to go wider. It's very difficult to open these instruments more and just provide enough exposure and retraction. I think when you're coming from below, it's easy to enter the wrong plane of the section because embryologically, the more difficult area where the proctodeon and the hinge fuse is right there at the point where you start, is easy to encounter important anatomical structures at the point where they are more vulnerable, like the urethra and also the nerves, and even the lateral pelvic structures, such as the branches of the internal iliac vein. So it has a potential for injury in those structures. You open the bowel unnecessarily in some cases. You can do a complete closed procedure, as I showed you before. And in many cases, the anastomosis ended being lower than really needed. So for that reason, we are not big fans of the TME. The literature now supports the fact that there are many complications. We use it occasionally, but not very often. So I think in conclusion, the degree of difficulty managing rectal cancer is variable, depends on many factors. The size and the type of the patient is one of them. I think easy cases are easy using any technique. Difficult cases are difficult. I think you have to choose your surgical technique carefully based on the characteristics of the patient, the tumor, and your expertise. I think embracing new technology requires a very thoughtful decision and a systematic institutional approach. So my personal opinion is that the robot is the best tool that we have today to perform TME surgery. I think it's precise. It allows you to perform the TME, a complete TME in most cases, allow the dissection all the way to the pelvic floor. I think in most cases you can do an anastomosis at that level, and if you cannot, then you can just work through the anus to complete the dissection and do a coloanal. I think it simplifies the stapling and the anastomosis. I feel much more empowered. I have much more control because I control the stapling device from the console. In my hands, once you pass the learning curve, it's a fast procedure. It doesn't take longer than open, as long as you follow a number of systematic steps. And you can standardize the procedure and always do it the same way. I think it's also good for education. We can teach the fellows. We have dual console in all of our platforms, so I give the instruments to the fellow, take them back, I demonstrate some step, and then I give them back to them for them to practice. I think the robotic TME delivers all the promise of minimal invasive surgery, less pain, faster recovery, lower complication rates, fewer additions, fewer hernias. So I think it just does what it's supposed to do for me. I mean, it requires institutional support. You need to have a team approach. You need to have proper training. I think having enough volume is important. Some people say that might add cost, but I think also increases value if you take full advantage of what the robotic has to use. We have to recognize that it will not make everyone an expert overnight. I think to be an expert, you have to have high volume, you have to work for years, and you have to understand the pathology and the anatomy. I want to just give you some tips for success. You have to convince yourself that robotics is useful in your practice. That's what I did. I started with the standard. At the beginning, I had access to the robot once every other week, only for one case. I just did the TME portion of the procedures, and I just stuck to that until eventually I had more access to the robot, more cases, and become, more proficient. You have to convince the institution that the robotics might be useful for them beyond the marketing. Okay, because I think you're gonna provide value. You have to build a team. Everyone involved in the care of the patient has to be part of the team and part of the effort. You have to have a backup if necessary. If you need to open a case, you have to do it. I think it's very important not to start with complex patients. And I will do that again. Don't start with complex cases. Try to start with simple cases. Set some time of what you are going to accomplish in that operation. Set realistic goals. At the beginning, it's okay to perform only portions of the case robotically. That's what we did when I started using the robot. We didn't have the equipment. The technology didn't exist to perform the mobilization of the colon. We just focus on the rectum and the mesorectal excision. It's okay to just do a portion of the procedure robotically. I think you have the XI platform, use it. I think every platform has improved from the standard to the X, standard to the S, to the SI, to the XI. With each new platform, the technology has improved. The last thing that we have been using is the table motion, which is quite helpful because allows you to use gravity to the full advantage. So what are the take-home messages? Well, surgery remains the primary treatment of rectal cancer, in spite of the, all the total neoadjuvant therapy and watch and wait. Still, most patients require surgery. I think a properly performed TME following defined anatomical planes represents the best opportunity for patient care and long-term outcomes. I think the benefits of minimal invasive surgery are real, but I don't think we have to keep in mind that those benefits don't justify the risk of recurrence associated with an incomplete mesorectal excision. Don't try to stick to laparoscopy or even to robotics to perform minimal invasive if the quality of the surgery is not going to be optimal. I think the robot is a tool that facilitates the minimal invasive surgery. In my opinion, currently is the best tool available for TME surgery. I'm sure that the technology will evolve and we will see new gadgets. I'm completely open to new technology. And I think you have to keep in mind that the development of a robotic program requires a coordinated effort between the administration and physicians. You have to have an implementation plan. You have to have some volume. You cannot do one case a year. And you have to have time and resources to do it. So I think I'm going to leave it here and I will just be happy to answer any questions.
Thank you. Perfect, Dr. Aguilar. We appreciate your thoughts, your history on robotic surgery. So at the bottom of your screen, there's a Q&A screen, a Q&A button, so you can submit your questions through there and I will read them as they come through. So Dr. Aguilar, first question is, are you using a 0 or 30-degree camera?
For the most cases, I use the 0-degree camera.
0-degree camera. Okay, wonderful. Another question is, are there any advantages with the robotic TME for erectile dysfunction and bowel bladder symptoms compared to laparoscopic TME?
I believe it is. I think it's an area that is not very well studied. We collect our own data and our experience is that the functional outcomes measured as erectile dysfunction using validated tools has improved over time. And I think a great part of that is due to the better visualization of the nerves and a more precise dissection in the pelvis.
Wonderful. Can you elaborate on the entry of stapler? Is it either suprapubic or right iliac?
I most of the time I place my 12 millimeter trocars in the right iliac, and I use that approach. Occasionally, for different reasons, we have to place the 12 millimeter trocar in other places, and I have done it from the midline, and I have done it also from the left iliac fossa. But my preference is the right iliac fossa.
Mm-hmm. What is the interval between the long course CTRT and surgery for rectal cancer in your practice?
Long course radiation.
Yeah, chemoradiation and surgery for rectal cancer in your practice.
Well, now, as I mentioned, we have great interest in the program of watch and wait and organ preservation. So what we normally do is what we call total neoadjuvant therapy. We do chemoradiation and chemotherapy, 4 months of FOLFOX. Sometimes before the radiation, sometimes after. After the total neoadjuvant therapy, we wait approximately 8 weeks, sometimes even 12 weeks, to give the tumor time to respond before we declare that the tumor has not responded and we take the patient to the operating room. But I think probably 8 weeks will be sufficient wait.
Okay. Do you practice diversion loop ileostomy for all post-CTRT patients in a selective approach?
I will say in general, yes. We use it particularly when we do a complete rather than a tumor-specific mesorectal excision. We are quite liberal with using flexible sigmoidoscopies. Using the loop ileostomies in patients when we do total mesorectal excision, particularly with radiation. Yes.
Does your data show that the robotic stapler leads to a better anastomosis?
It's very difficult to say because, as I mentioned, we didn't have that much laparoscopic experience. But in general, I'm quite satisfied with the robotic stapler. I mean, our comparison will be with the days where we were using a TA stapler to transect the rectum versus now the robotic stapler to transect the rectum. We did not observe any increase in leak rates or problem with the anastomosis with that transition from the TA stapler to the robotic stapler to transect the rectum. No significant change.
Mm-hmm. What is your experience with locally advanced cases requiring extensive resections?
You can do them. You can do some extensive resections. I think we work sometimes with our gynecologists, and we work frequently with our urologists if a tumor is involved in the seminal vesicles and things like that. In general, we need to do a complete pelvic centration, even though it can be done robotically. Until very recently, the urologists felt not very comfortable doing ileal conduits, so very often we made some degree of incision for those procedures. But sometimes we do extended resections, removing a seminal vesicle, or again, doing an hysterectomy or a vaginectomy. That can be done robotically without much difficulty.
Mm-hmm. How many cases a month do we need to do to keep our skills?
I think it depends. I think as many as possible. There are not many people who do one rectal cancer case a month. That's 12 a year. But I think that probably will be a very good number. Some people can maintain the skill with less rectal cancer cases. They do other type of cases. In addition to rectal cancer, we do all of our colectomies nowadays using the robotic platform. Some people that might be doing some general surgery might be doing other procedures. And so they can keep the technical skills up by doing hernias or doing gallbladders. So I think in general, whether you're going to do open laparoscopic or robotic, you're going to be doing rectal cancer. I think it's appropriate that you do a number of cases every year. Again, that applies to robotic or open or anything else. If you're going to be doing robotic, the greater the number of cases, the greater the opportunity to work with the machine, the better it will be for you.
Mm-hmm. How do you check anastomosis integrity during surgery?
Well, I think I'm very strict when it comes to the length of the conduit to make sure that the anastomosis is not under tension. We are also quite strict about the blood supply. You know, the issue of the ICG is controversial, but I use it. When we sterilize the colon to place the anvil outside, I check the pulses. So I'm very strict about all these things. Once we create the anastomosis, we check the anastomotic rings to make sure that they are intact. And we perform a flexible sigmoidoscopy, do the Ehrlich test, you know, submerge the anastomosis in water or saline, and then insufflate with a flexible scope. We check the anastomosis visually with the Tile Pro. That's what we do. Even if we're going to do a diversion, we like to check it. I think it's critical to do that.
What about adding AirSeal for robotic TME cases? Do you use it?
Yeah, now we use the AirSeal systematically. I think it has been another significant development. I think is better in general to maintain the pneumo and to reduce fogging. I think it's a good tool. We use it. I like it. We use it systematically now.
Okay, wonderful. Do you mobilize splenic flexure regularly in TME?
Routinely. When we are going to be doing a TME, as I mentioned, probably this is not the conventional way. I identify the inferior mesenteric vein right below the pancreas. We are now pretty strict about reviewing the vascular anatomy. You know, on the CT scans, you can see the vein, you can see the arteries very well. You pay attention to what you get from a high quality CT scan, particularly in the coronal view. So we plan exactly where we are going to cut the vein, understanding where the branches of the left colic are and where the blood supply is coming from. And then we just proceed medial to lateral. And then we just go over the pancreas to get into the lesser sac all the way to the splenic